Good afternoon, everyone. My name's Aaron Das, and I'm the Deputy Programme Manager for the Community CAMS Quality Network. I'm delighted to welcome you all to this live event. This will be our second in a series of webinars that we've put together to take place over the coming weeks and months to support the community CAMS services across the country during this difficult time. For anyone not familiar with the network, QNCC sits within the Royal College of Psychiatrists and sets standards of care for community CAMS services. QNCC works with member services to identify examples of good practice and areas for improvement. We'd also usually offer a series of events and networking opportunities. So, in the absence of face-to-face contact, the aim of these webinars is to provide a space where teams can share experiences and discuss new ways of working. Before I hand you over to Carol Ann and Phil, who'll be taking part in today's session, I've just got a couple of housekeeping points to go through. The session is a live event, therefore your microphone and camera will be turned off unless you are a speaker. The webinar will be recorded and uploaded on the CCQI webinars webpage. Please use the chat function to ask any questions, and you can vote for the ones you want answered the most. Use the chat box to let us know if you would like any specific topics covered in future webinars. So now I'm going to hand over to our QNCC Advisory Group members, Carol Ann Murphy and Phil Ferreira-Lay. Carol Ann will be interviewing Phil on his experiences of managing the COVID-19 crisis within the community CAMS services at Surrey and Borders Partnership NHS Foundation Trust.
Okay, so good afternoon everyone, and some of you may have tuned in 2 weeks ago when I was interviewing Tracy Beattie, who works in North West Boroughs with me. So everyone, I'm going to be interviewing Dr Phil Ferreira-Lay, as I just said. We will be talking for about just under half an hour. Please feel free, as questions arise throughout when we're talking, to ask in the Q&A, and I will endeavour to get through them all before 4 o'clock. So how are you, Phil?
Yes, good. Thank you everyone for joining us and being able to share together.
Yeah, and how are you? I mean, I know I spoke a lot with Tracy about how we were coping up here up north in North West Boroughs. How are you coping during all this COVID-19 in CAMS in Surrey and Borders?
So I think it's been both challenging and exciting. So, 10 or 11 weeks in since we've had to radically change our ways of working, we've definitely learnt how to use remote working alongside, face-to-face working as we try and look after young people that are still being referred to our services. It's been, on behalf of all our staff, I think fair to say it's been an exhausting time with people really working long hours and working creatively. But nonetheless, it's been a good time in lots of ways as well, as we try and work with families and with our system partners to make sure that young people's needs are met, despite all the challenges I've mentioned.
Fabulous. And have you noticed an increase or a decrease in referrals?
Well, it's been interesting because in Surrey and Borders, we have our community CAMS services, but we also look after most of the community paediatric services, and both of those, for the most part, referrals come through our single point of access. So it's fair to say, at the risk of simplifying it a bit, that in the early stages of the past, 2 to 3 months, we noticed, a definite drop-off in referrals. And that's probably due to, self-isolation and young people not being at school. But what we've noticed in the past week is that actually the number of referrals does seem to be picking up again, as does the complexity. And we suspect, amongst other factors, that is related to the fact that, schools are going to come back on and be face-to-face from next week. And also the challenges that all of us, have had as family members ourselves, really, with young people, eventually, in some ways needing extra help and support. So it's been up and down, but we're prepared for what we anticipate is going to be an increase the sustained increase in referrals.
Yeah, and I think there, I mean, you alluded to, you know, yourselves having families, because obviously we go to work, we're not just workers, we are individuals who belong to some sort of system outside, some family. So how are your staff? How are they? Have they been impacted? Have your staffing resources been impacted?
I have to say it's probably been, you know, on a par with the challenges that actually running our services has presented us, because, you know, we all know that if we don't look after our staff and have our staff as well as they can be, then actually the service that we're able to provide, you know, isn't as good as it can be. So I think in the early stages, in common with lots of other organisations, I think, you know, because, you know, the command structures that were put in and directed by NHS England really took precedence. It's over the period of time since then that we've really doubled down on efforts to support staff, make sure that actually, you know, they are encouraged to take leave and annual leave. There was a period in time when we thought there was going to be a massive surge across not just Surrey, but the whole of the country at the beginning of April, where, you know, rightfully we were all asked to defer annual leave, and actually, thankfully, that surge didn't come. So for us, it's about how we keep all our staff well. We have had some staff, you know, at home and then needing to return after periods of self-isolation, and now it's about how we, you know, build in and maintain capacity for the longer term as we recover and restore to a more business as usual situation.
That's right, and I think part of what you read in the media, what you hear in the media, the business as usual is never going to be business as usual as we've known it. And it is all that whole thing about before we might not have even thought, we think risk management, but this is a new little bit to put into risk management or risk management tools. Have you started doing any work around that?
Yeah, so, you know, we have, obviously in line with national guidance, on a daily basis through our sort of gold, silver, bronze command structure, which is nationally mandated, you know, enabled there to be two-way communication between, you know, frontline staff in all our services, and then through divisions, and then to our exec colleagues and our chief exec. And one of the things you rightfully point out is around, you know, the safety of staff and young people and COVID testing, and how we factor that into our risk profiling and then our risk management. So, you know, we've got risk assessment tools now in relation to staff, and how we identify those staff who may themselves be at direct risk or through family circumstances. And then also we've done quite a lot of work and continue to do work around how we risk manage all our young people, from our complex high-end tier 3.5 caseload and eating disorder caseload, all the way through to our sort of primary mental health, school-based workers who have been doing ongoing work remotely, supporting Senkos and head teachers as they have been doing online teaching of their pupils. So we've got measures in. We're still refining those in line with many other organisations, but they're definitely there.
Yeah, and I think tied into that, you've just said about young people with eating disorders. There will always be a client group who need to come to clinic or who need home visits, because just because COVID-19's come doesn't mean that they can just have face-to-face. And I'm not minimising face-to-face at all. I think for some young people it's been a godsend. However, in terms of the physical checks, so have you increased, like, so say a young person with an eating disorder is coming to clinic, or you're going to do a home visit, have you increased like temperature recording or any other ways of managing that risk?
We have. I mean, we've been fortunate, I have to say, when I compare some of our neighbouring trusts, that actually in some ways we have been quite ahead of the curve when it comes to digital solutions and remote working, in support of still that face-to-face contact. So yes, what we've done, you know, in our children's and adults eating disorders has been very systematic in enabling, you know, monitoring clinics to continue, in relation to sort of weight, in relation to, requesting for physical monitoring, bloods, ECGs. I mean, it has been challenging because, of course, whilst there are things we can do in-house, we've had to work very closely with our acute colleagues in district general hospitals and our general practitioners to make sure that overall we're keeping, young people safe. But as the weeks have gone by, we've been bringing in cohorts of young people, normally the riskiest young people for face-to-face support, and also we've been maintaining, social distancing expectations alongside that, as well as the PPE element to things as well.
Fabulous. When you said there as well about your colleagues in the acute care and GPs, do you think this will enhance your relationship with people like GPs who sometimes, I don't know about down south, but sometimes up here in North West Boroughs, they are our highest referrer and we tend to get along really, really well, but they do get frustrated sometimes. So do you think it's enhanced your relationship?
I think overall it will. I mean, I won't pretend that it's been, seamless, because there have been one or two instances where we've had to escalate through the system, particular cases where either there's been a misunderstanding of who does what, how and when across the system, or in fact, actually when all of us are challenged with continuing to work and look after ourselves, it's about the timeliness of things being done. But we're fortunate in one sense, having said that actually, we're well embedded within two integrated care systems where, as the main provider of mental health across, Surrey and North East Hampshire, we're involved in all those system conversations, and I've had conversations with GP clinical leads, as have some of my colleagues, around, how we maximise the effectiveness of what we do. Because, of course, GPs face similar challenges to us about how we target our time and our resources, whilst also letting the public know that, no services are closed. We're all still here trying to look after young people and families together.
Yeah, that's right, 100%. Because I think people think that unless you're acutely unwell with COVID-19, the doors are closed. But like you've just said, we are all still working. One of the things that came up the other week and continues to come up, people are generally feeling quite anxious, I think, about the fact that the services for young people who may be on a neurodevelopmental pathway may have halted completely, because obviously you can't just go into schools and do assessments. It's difficult to do ADOS or whatever other testing. How are you managing that down south?
So, in fact, we're fortunate in that we've got, committed, passionate staff, ranging from, assistant psychologists to nurses and to doctors and non-medical prescribers. And I think in common with other services across the country, probably it's the neurodevelopmental caseload that presents the biggest challenge nationally around capacity and demand issues. But we have, been trialling, through individuals and then teams, remote working, remote assessments, or at least elements of that, using, applications like Attend Anywhere and Microsoft Teams. And actually what we're hoping, because we're in the middle of an ongoing transformation process with our system partners, is we're hoping to bring all that expertise and knowledge and on-the-ground learning to bear as part of our longer-term solution, because I think what COVID-19 has definitely presented us with is the challenge and the opportunity of trying to get as much sort of support and intervention as far upstream as possible, be it, in the nurseries, be it in the schools, rather than necessarily thinking that all the problems are for community paediatric services or CAMS. So it's an interesting time, but digital solutions, remote working has been part of that already, and I envisage it will continue alongside face-to-face.
Yeah, fantastic. And I think I've I'm really, really pleased that a young person who I'm working with, obviously I'm not going to break any kind of rules here talking about confidential items, but the young person wouldn't engage face to face, and he's actually really engaged well using phoning me, emailing me, and it's amazing. And the social worker's like, seriously, weekly? Oh my, she can't believe it.
I agree. I mean, I think it's interesting that for some young people, lockdown has been, for them a bit of a godsend in that you don't have to socially interact, and if you do, you can limit that to online interactions, whether that's good, bad, or not. And then for other people, actually, over time, this sort of set of circumstances has added to their anxiety. If not themselves, then their parents, and then of course as family units. We've had to be mindful of that. So I think for us, what we've been conscious about is that we're constantly reviewing and RAG rating our caseloads. And when it comes to support for young people, we are engaging in conversations with them about what does that best look like for the individual? Because I agree, on a call this morning, my young person I was speaking to felt really comfortable, just speaking on the phone, and she didn't want to be on a video call. And at the moment, she's not so high risk that I'm going to require her to come in. So it is trying to find that right balance, and it does require staff, and this is an ongoing challenge to all of us, actually to be really flexible and creative in the ways that we work, because then that maximises our efficiency and effectiveness, to serve the local populations.
Yeah, I think 100% agree with you there about staff being flexible. And I think I was looking back, doing a bit of an archive of my emails, and back in 2012, we were having a discussion about texting young people, and it was the staff's anxiety back then that didn't want it to happen. What if they text me when I'm not on work? What if this? What if that? And here we are now, actively encouraging phone calls, actively encouraging the use of technology, and it's like, who had the anxiety, I wonder,
Exactly, and I think it is for sort of, all of us as leaders, and when I say that, I think all clinicians and operational staff that we work alongside have an opportunity to lead and support, teams and services. For me, the past 9 years that I've been in our organisation, I've definitely noticed a shift whereby, and that's what makes the work exciting. We're constantly being challenged to be creative because of the young people that we're serving are existing in ever-changing times and contexts. And so what I hope we try to model to each other in my clinical team here, where I'm calling you from, and then in my leadership role, is actually, what is the most sensible, pragmatic, good enough creative solutions that we can give to young people, and that does depend on strong, clear, coherent, both clinical and operational leadership across the board, across all our services.
Definitely. One of the questions as well, and something that I know some clinicians have been a little bit anxious about, was if you have young people who are in old money tier 4 beds, inpatient units, and they're perhaps getting ready for discharge, how are your services managing that really?
So it is a challenge. We don't have any tier 4 beds within Surrey and borders, but we do have strong links through our collaborative tier 4 collaborative work with neighbouring organisations, both in the public and in the private sector. But what we do have, both in our eating disorder services and in our what I would say old money tier 3 services, is we have really good step up and step down provisions. So we have nationally accredited eating disorder services that really lead the way in lots of the ways that we've been considering, and also we have a sort of jointly commissioned service called the Hope Service, which is education, local authority and health provided, which is all about both making sure that where we do need to admit, because accessing national beds when so many units are currently closed or understandably gatekeeping access to them is in the most targeted way possible, but then also making sure that we have an assertive approach to helping get young people out of Tier 4 provision back into the Surrey area to be closer to their families, etc., etc. So you know, it's ongoing work, but I think we're well connected, which also relates to what I said earlier about being fully embedded in our integrated care systems.
And that's really good, really helpful, because I think as well there's quite a lot of beds that previously it's really difficult to source a bed, but I think there are beds now because people have been more, well, either more reluctant that they want to go into hospital, or maybe they're as you said then about Tier 3 really being creative in how they're working with these young people to stop, you know, so it really is only the neediest people who are in a bed.
Yeah, there's that, and there's also the, you know, the issues that present themselves at transition when we're thinking about, you know, young people who either are going to need adult mental health services, plus or minus, you know, we can foresee possibly needing to access adult mental health beds, which we do have within our organisation. So again, for me and for a lot of my colleagues, you know, almost on a daily basis, in one sense, unfortunately, but in another sense, rightly so, we're involved in escalation calls around how we can identify the most sensible, safest solutions that are creative, that try and reduce inpatient admission, but where it is needed, that we've got all the checks and balances to make sure that, you know, that young person is safely cared for, and that communication with families, with you know, clinical colleagues, is as tight as it can be, so that there's no misunderstanding or sort of lack of clarity about who's doing what.
Fabulous. I know you said there about transition, about adult beds and things. My main role really is in transition from CAMHS to adults, and I know just prior to March the 23rd, there was a young person who we were working with. He was in an adult bed and just 18, literally, and in an adult bed, and COVID struck, and it was a bit like, oh my goodness, how do CAMHS, because you don't just close because they've gone right over if they need that transition period. And it is that bit about speaking to staff about it is all right to keep that young person working together, because COVID shouldn't be, oh my word, we've got to stop now. It should be, well, let's just work through it.
Yeah, and I think what you're speaking to, and I would agree, is that sometimes what can happen is that sometimes, you know, services can act in an overly rigid way. So, yeah. You know, and that's understandable in one sense, because that might be linked to, you know, the skill competency and working within registrations and then, you know, regulatory requirements. But at another level, what COVID has really provided us an opportunity to do is actually to use those escalation calls as a way of truly sort of being pragmatic and sensible wherever we can, and actually being hopefully quick enough that if the needs or the context change, then we can respond quickly as well, because obviously, you know, these young people come to the attention not just at transition points at 18, but also between, you know, criminal justice services or forensic services or presentations in A&E or similar. And so for me, it's the relationships. It's, you know, do I or my colleagues have the right connections, the right relationships, so that we can make decisions based on trust without having to go through too many unnecessary hoops.
Good. No, that makes sense, and it should be about need and about working together and not letting policies and everyone being too rigid get in the way. I'm just aware it's 15:43 now, and we've started some questions coming through. But the first one actually alludes to what we were talking about the neurodevelopmental assessments again. And someone has asked, I'm not sure on their name, but what I was asking you before about how you were managing, and they were saying about what are our thoughts on child assessment while socially distancing or via video platforms, attend anywhere, and you said about that you're doing that.
Yeah, so we've done it so far in a relatively small scale. because what we want to make sure is that actually you've got a considered approach around that. But yeah, some of our psychiatrists and I think some of our psychologists have definitely been using that. So if I give an example, you know, across our neurodevelopmental pathway workforce and our community CAMS workforce, we've got assistant psychologists who will, you know, be involved, for example, in taking developmental histories, and they may or may not also be supporting other staff like our psychologists or our doctors in relation to doing assessments of the young person's, you know, functioning. When I've seen the reports that are coming out of that, both in terms of, you know, service transformation ideas, actually that is building on a blend of, you know, remote working and face-to-face working. But obviously what we've had to do sometimes is stagger how we do things. So it might be that the, you know, developmental history has been done, for example, pre-COVID times, and then it's about how we might be able to do the face-to-face interview, you know, through Attend Anywhere or Microsoft Teams, you know, during COVID times, and then capturing all of that wealth of information in the reports we write. And of course, what we're trying to do is, because of the things you said earlier, that some people prefer not being face-to-face, is what can we build into our business as usual going forward with our partners around the right combination of face-to-face work and remote working. So there's work in hand on that already.
I wonder, I mean, I'm just as we were talking there, I was just wondering, do you think maybe we'll get those neurodevelopmental assessments done actually quicker?
I think there's the scope for that. I mean, one of the things that I think, you know, all our services are challenged with is how do we target support and intervention which doesn't necessarily need to translate into having a formal diagnosis. So I'm of the view, and there are many of us, you know, in our local system that hold on to a view that obviously, you know, young people and families rightfully, you know, expect and need support and intervention from us alongside education and SEN colleagues. But actually, can we use COVID again as another opportunity to continue those discussions about, you know, do we necessarily need to do formal assessments on all the young people that may or may not have neurodevelopmental traits? I think there's definitely a debate around that when it comes to autistic profiles, whether we agree with that or not. There's also a similar debate that can be had in relation to ADHD. One difference, though, clearly is in ADHD, where we're talking about non-comorbid conditions, is actually, you know, you are invariably, if you're not providing behavioural support and adding in medication, sometimes, you know, medico-legally, you will need the formal diagnosis to enable the medication. But we're having system conversations around what does flexible, pragmatic support and intervention look like, which may not always mean that we need to diagnose everybody to kick that all off.
Good. Hopefully that will answer the question that was asked. Sorry, I don't know who it was because they haven't given us their name. We have another question. Again, sorry, I don't know whose name it is, but how are you supporting new staff who have started into service during COVID-19? So have you had many?
Well, that's really timely, because a timely, important question, because actually, you know, my HR colleagues have been working flat out. So, you know, when I've been based down at our headquarters, as well as here in my clinic, you know, I've seen, you know, staff being inducted, obviously still socially distancing. So we are recruiting, you know, we have been recruiting people throughout the whole of this period. And which is good, because actually I was a bit fearful right at the beginning that all sorts of corporate functions, you know, would stop. And of course, all organisations have turnover of staff, but again, it's how we sort of work together with our HR staff. And then once people come into place, and I was talking with some doctors this morning about how we're going to induct a new non-medical prescriber again, once people join us, and they do join us, is what does their local induction look like? What does their corporate induction look like? How much of that can be, transferred into online solutions? So we are continuing to work and develop that wherever possible.
Fabulous. And someone else, again, people are being shy today with their names, which is entirely appropriate. But how have you been managing aspects like to record clinical contact hours and outcome data? How have you been managing that? So,
I mean, it's been interesting. There's always been a long-standing challenge around, how you accurately record face-to-face contact, versus indirect consultation. But, that's a long-standing issue. That's not just COVID related. But, my impression, both in relation to my own work and then my colleagues, is actually we've continued, recording in our sort of electronic patient record, appointments. We've been outcoming them. We've been scrutinising them through our divisional management group that has continued to meet remotely. And obviously at each team level or base level, we've got service managers who are trying to make sure that we get the right balance between people continuing to have, contact with families and then recording it. I have to say it's been interesting where, obviously because people are typically attached to their seats working for long hours of the day, the temptation could be is you could be working unwittingly not 8 hours or 9 hours, but 10 or 11 hours, because of course you're not having to do the home to work journey. But again, what we've been keen to do is make sure that our senior clinicians work alongside the service managers to make sure that we do factor in breaks in meetings, and we do that, at every opportunity. Fabulous.
And then a really interesting question. Obviously, we're not going to be in this situation forever. And how are you planning on services returning for both young people and staff on a face-to-face? And again, I don't know the name of the person to respond directly to them. How are you planning on that? Has anything been planned yet for more face-to-face again?
Yes, so it's been something that our trust, and therefore all our divisions, of which Children and Young People's is the division that I'm primarily involved with, it's been on our agenda pretty much from the word go 10 or 11 weeks ago. And in more recent weeks, as we've had increasing clarity, from, the government, from the Royal College of Psychiatrists, from CQC, about what recovery, we termed it recovery and restoration. How do we exit the ways we've been having to work over the past few weeks, keep the elements that we think we need to retain, but also then sort of shift back to more of that face-to-face offer. And what we're doing, I'll give a couple of examples, is we've never said to our staff or any of our teams, you must not see people face-to-face. What we have said is, look, that needs to be where it is done face-to-face. So, for example, in our crisis teams, or when we're doing duty work, or, for example, in our eating disorder team, it's got to be linked to a real clinical imperative. Now, what I envisage and what we've got plans already at a very detailed, advanced stage is around how we establish and what those principles are within the whole of the trust, of which my division is one, and then what's the local implementation going to be around those principles so that we get the best sustainable combination over the coming weeks or months, because there's going to be a version of COVID-related activity, I imagine, this is my own personal view, for at least 6 months to a year.
At least, yeah, at least. No, that's really helpful, and it leads really well into this next question about. So we've spoke about the data before, about outcomes and everything. However, this person's asked, how are you monitoring the data on the changes that are being made, so to make sure that any positive changes are carried forward into future practice? And that's what we kind of said earlier in this discussion, that there will be things to take forward. And how will you know what they are?
So I think it's the range of things that we would do ordinarily, I would argue. So obviously we take service user, young people, family feedback. We also are in regular conversations with, stakeholder groups, both, neurodevelopmental related and non-neurodevelopmental related. We also have, regular scrutiny from, local team all the way up to the weekly exec safety huddle that I'm part of around complaints, both formal and informal, and then SIs, HLIs, all those sorts of things. And then actually what we're also, because we're part of a partnership arrangement, so we have, the local authority involved with us in delivering services, we have, voluntary sector, we have local and national charities involved like Barnardo's and National Autistic Society. Again, it's about gathering the intelligence from our, if not weekly, then fortnightly and monthly, standing meetings that inform what we do and how we do it. And then, of course, we've got the feedback that we get from our outcomes reporting, if we're talking about, success or not of interventions, that we report through our, care quality, review mechanisms with our CCG and our local authority colleagues. Okay,
thank you. With a bit of a different question now, and one that I've answered this morning already on a different forum. Have you seen an increase or a decrease in levels of self-harm?
Well, it's hard to say whether it's across the board, but we have been alerted, here in Surrey and across the border in Berkshire, around a cluster of young people with what it seems is a neurodevelopmental profile around anxiety and self-harm, which we're in the process of really understanding and then sharing our learning, across our whole system. So I think it's fair to say that, self-harm does continue. We've no reason to believe that it would go away, but the true extent of it, I think, is only going to become apparent as people come out of their homes more, and we get sort of 360-degree visibility on all of that. Yeah. With our school partners, with our school, our Senkos, our head teachers. And of course, that's a lot of the work that we're trying to do with our primary mental health workers and others, and school-based workers, is how do we both recognise where a young person is struggling, what do we do to prevent and therefore limit deterioration with which, self-harm might be part of it, and then what does the intervention look like, and then what are the principles where you might have clusters of kids that we can apply across the whole system through our training or through our monitoring mechanisms.
Yeah, and I guess that's pre and just to sum that bit up, that's not just during COVID, that's something we can carry on with.
Exactly, exactly. It's how we use the current opportunities and challenges to inform what's the longer term sort of direction and what are the key areas we need to keep sighted of. And neurodevelopmental cases and young people, definitely. Self-harm, suicidality, definitely. Eating disorders, also, and then our crisis care, because wherever possible, what we want to do is reduce footfall into A&Es, and not just because of COVID, but because actually, wherever possible, we should be doing everything to reduce the need for that to happen in the first place.
Exactly. Just tied in there again, we've just had a little idea through that it would be really good to have a session on how different areas are doing neurodevelopmental assessments, maybe as an interactive forum, because lots of people are having discussions. And then this is going to be the last question. So how has the research about the impact of the pandemic on mental health been collected and evaluated by services, and how will this inform assessment and treatment planning going forward? Now, that's a really big question for a 2-minute answer.
I'll give a particular element that has been really key in our thinking, and obviously nationally and locally we've been aware about the gathering data around how the Black and ethnic minority populations, both in terms of workforce and service users, have been impacted. And of course what we're doing is through our sort of monitoring of the national situation and the data that comes through there, and then what we pick up locally through our intelligence and our risk assessment. So I mentioned risk assessments of staff and young people earlier on in the call. That's a good example of how we're really learning about both the nature of this, virus, its impact upon cohorts of people, and then how services need to orientate themselves around those cohorts so that actually we keep people well and still do the best job we possibly can. It's been a steep learning curve for all of us.
And I think it'll continue to be steep. Well, I think it will be continued. And I really apologise to whoever it was that asked about the thoughts on decreased referrals and what will be the pressure points on as lockdown's been lifted and where should CAMHS focus its worries. I think maybe we could ask that through the Knowledge Hub. Because I'm really, really sorry, but because we've run out of time and we've got to be off at 4 today because there's another webinar happening. So I'm loving all the questions. However, I'm really, really sorry that we haven't got to do justice to the last 2 properly. However, Aaron, I'm sure we could maybe through the webinar, through the Knowledge Hub, expand them into big questions. Can I just say thank you so much to everyone who's participated. Thank you to Dr Phil Ferreira-Lay, who has been my interviewee today. And thank you for the college for setting this up.
Thanks, everyone. Take care, everyone.
Thank you.
Excellent. Thank you, Carol-Anne and Phil, for your time. We have, just as Carol-Anne mentioned, we have a new online platform called Knowledge Hub, where you'll be able to post your questions on the dedicated COVID-19 Mental Health Improvement Network. Some of those queries that have come up, as Carol-Anne mentioned, we will be posting those onto that network itself. You're also able to sign up for the QNIC and QNCC networks there too. We'll also be uploading this session onto the CCQI webinars webpage shortly. If you are interested in presenting a similar webinar session, please do get in touch with the team via our email address qncc@rcpsych.ac.uk. Thank you everyone for joining us today. We hope you found the session helpful and we hope you have a lovely afternoon.